Well, good afternoon, everybody, and welcome to Biostatistics in Action, Tips for Clinical Research lecture series. This series of talks is organized by CTSA in collaboration with the Department of Biostatistics. The speaker, our special guest today, is Dr. Bruce Levin, professor and past chair in the Department of Biostatistics. Dr. Levin has extensive expertise in designing and consulting for clinical trials. And today he will present a very interesting study and point out how not to conduct a randomized clinical trial. Without further ado, Dr. Levin.
Thank you, Cody. Thank you. Thanks very much for coming on this hot and humid day. Cody does have printed handouts of my talk, so you don't need to take notes if you prefer not to. And although I am inclined typically to give technical biostatistical talks, I promise you today there won't be a single formula, and this is a non-technical talk. Nevertheless, it's going to raise some subtle issues about the conduct of a randomized controlled trial. I want to say that I'm going to be using one trial, the PACE trial, which we'll describe in a moment, as the vehicle, because as it turns out, it is a great teaching example for how a well-designed, well-conceived randomized controlled trial can go off the rails and cause havoc and controversy and raise serious ethical concerns. So although it's about one trial, there are many learning points that I hope to point out during my talk. I want to give some heartfelt acknowledgements, first and foremost to David Tuller, who is an investigative journalist and until recently ran a joint program in public health and journalism at the University of California, Berkeley. Without his courageous investigative journalism, I don't think we would have the knowledge and understanding quite the same way that we do today. Much more than an acknowledgement, you may discover that I've actually plagiarized much of David Tuller's writing, but I wrote to him and told him about this acknowledgement and confession, and hopefully he'll understand. As well, Carolyn Wilshire for her profound psychological insights. I am a co-author, I'm honored to be a co-author of a paper she and others wrote to reanalyze the original clinical endpoints for the PACE trial to see what happened, and therein hangs a tale. To Vince Racconello, our own professor of virology, for putting up the many blogs that David and others have written about this subject. If you don't know virology blog, please check it out. And to many ME/CFS patients, especially Alan Matthews and Julie Raymeyer for conversations and profound insights as well. So for background, in February of 2011, United Kingdom researchers published a paper in the Lancet entitled Comparison of Adaptive Pacing Therapy, Cognitive Behavior Therapy, Graded Exercise Therapy, and Specialist Medical Care for Chronic Fatigue Syndrome, the acronym of that trial being PACE, a randomized trial. The authors are P.D. White, M.C. Sharp, Trudy Chalder, and others listed in the citation below. One comes with a presumption, perhaps, that a major article published in the Lancet would have great credibility and should be given serious attention, and so it was. Let me digress for a moment. Throughout today's talk, there'll be a complete schizophrenia between British spelling of words like behavior with a U or randomized with an S, and the American spelling without the U or with a Z or Z, as my Canadian friends say. as opposed to an S. That's because I've quoted liberally, shall we say, from the original writing, so sometimes I'm quoting a British version, sometimes my own American version. The Lancet article reported that 2 rehabilitative treatments, cognitive behavioral therapy, CBT for short, and graded exercise therapy, GET or GET, were safe and effective treatments for patients with a particular syndrome known as, in the old days, chronic fatigue syndrome, today more appropriately called myalgic encephalomyelitis, or MEs, or MECFS for short. The effects were statistically significant and seemed quite substantial when you read the paper. The paper is here, if anyone would like to see it after the talk. Again, let me offer a disclaimer. I am not a clinician. I'm a biostatistician. I have a PhD, not an MD. And so if I appear to be knowledgeable about the syndrome, it's only because I've learned these words. You know, I play one on TV. And I call on the more clinically knowledgeable people in today's audience to correct me if I make any errors. As a result of this Lancet paper, in fact, let me circulate the paper as we speak. Please pass this around. The PACE trial received a lot of attention, international attention, and had widespread impact on research, actual treatments prescribed for patients, and attitudes toward the illness, both in the medical community and the patient community and the public at large. For example, what got a great deal of attention was at the time of the publication of the 2011 Lancet paper, there was a press conference held by the investigators to promote the Lancet paper, and one of the lead investigators, Trudy Chalder, stated, and we quote here, "Twice as many people on graded exercise therapy and cognitive behavioral therapy got back to normal." She used the word normal, compared to those in the other 2 study arms. The other 2 study arms was a modality called adaptive pacing therapy, and the control arm was specialized medical care, what we might think of as standardized medical care or standard of care, but BS referred explicitly to specialized medical care. If I call it the control group, that's what it is. Its function and purpose was to serve as a control. In today's talk, I'm going to focus just on CBT and GET, not so much on adaptive pacing, for the simple reason that in the original trial, adaptive pacing therapy looked almost identical to the control arm, and so there's very little there, but I just wanted to remind you that this was a 4-arm randomized controlled trial. Furthermore, an accompanying commentary in the Lancet claimed similarly that these back-to-normal participants had met a strict criterion for recovery, when you could read those comments at the time of the trial. So this is important stuff, and you have to pay attention to it. I'd like to try to clarify what the underlying hypothesis the investigators had, which justified in their minds the use of cognitive behavioral therapy and the other modality, graded exercise therapy, which was that ME patients harbor unhelpful convictions about having an ongoing organic disease, and that the perpetuation of their devastating symptoms is the result of deconditioning. Therefore, it would be plausible that CBT or GET could help. In other words, if patients are afraid of having relapses when they exercise or exert themselves in any manner, they're going to be afraid to do so, and their muscles become deconditioned, and it involves a vicious cycle. So if only we can intervene cognitively to change their behavior, to alleviate their fear, maybe we can get them past the psychological impediments for rehabilitating. This theory, somewhat unkindly, something I call "it's all in your head," stands in stark contrast to a recent Institute of Medicine, now the U.S. National Academy of Medicine, review. In 2015, the IOM reported that ME/CFS is a complex, multi-system illness characterized by neurological, immunological, autonomic, and energy metabolism dysfunctions. In terms of diagnosis, the cardinal symptom that these patients exhibit is a systemic intolerance to exertion. If patients exceed their available energy resources, they can suffer serious and prolonged relapses. Those of you familiar with this disease know that it's devastating. Sometimes patients can't get out of bed. We've seen films, documentary films, where patients had to excruciatingly crawl up the stairs just to get into bed and then could not get out for weeks on end. Unfortunately, the etiologic mechanism underlying of the disease is still unknown. There are hypotheses that it's all in the mind. There are other hypotheses that this is some unknown sequela of a viral infection. There's some evidence for that because onset of such symptoms often follow viral illness. A number of years ago, our own Ian Lipkin here at Columbia was involved in an NIH-funded study to confirm or refute the hypothesis that the specific viral agent might be XMRV, xenotrophic murine leukemia-related virus. It's a type of virus that has symptoms of leukemia in a mouse model. But that turned out not to be the case, somewhat unfortunately, because everyone was hoping this might be the causal agent. But in a study I was involved in designing with 150 cases of ME/CFS and 150 controls, in a retrospective design, we looked for the prevalence of XMRV in cases relative to controls. Well, the answer was there was no virus found either in the controls nor the cases. So this is certainly not an explanation. A more believable explanation is that the assay for the XMRV had to be so exquisitely sensitive that it was picking up mouse molecules in the saliva when the mice went into the warehouse for the laboratory assay reagents and started nibbling through the burlap sacks, believe it or not. Left a few mouse molecules, and that looks like XMRV. So this is certainly a subtle disease, not so subtle in its manifestations, but certainly of unknown etiology currently. Other hypotheses are that it's exposure to mold toxins. Julie Rehmeyer, for example, has written a book in which she purports to have been alleviated of her symptoms when she went to a stark mold-free environment in the desert in Arizona. You can imagine, though, that if this PACE trial were not armor-plated, foolproof, and credible, patients may have some concern about the underlying theory of the rehabilitative modalities. In a nutshell, patients have said, and I believe them, "What do you mean this is all in my head?" Let me tell you, this is not in my head. I cannot move, and there's something wrong with me. It's not a psychosomatic illness. So I'm here to discuss certain peculiarities that were brought to light thanks to the vocal participants of the PACE trial in the United Kingdom about some troubling peculiarities. This is perhaps one of the most outrageous peculiarity, and one in my entire career I had never seen before in terms of biostatistical concepts. Patients' baseline scores for the two primary outcomes, one being physical function ability, and we'll talk about how that's measured, and fatigue, and we'll talk about how that's measured, could qualify them simultaneously as sufficiently disabled to qualify as eligible for the trial. After all, you have to have eligibility criteria for a trial of this syndrome for patients. But as well, already recovered. The day you're enrolled in the trial as eligible for treatment, you can be recovered. That's weird. This happened because the criteria for recovery were changed months after the data collection was completed, sometime between when the statistical analysis plan, which is required for a formal phase 3 randomized controlled trial, sometime between when the analysis plan was finalized and the publication in 2011 came out, something happened. The endpoint for recovery was changed. Now, the investigators claim that this was done before they looked at the data and with the approval of the Ethics Oversight Committee. But as good skeptical biostatisticians, we have to ask ourselves a few questions here. First of all, the PACE trial was not masked or blinded regarding treatment group. The revised endpoints were subjective, self-reported outcomes. They were not the originally pre-specified objective measures as stated in the trial protocol. It was not clear to what extent the Oversight Committee was independent of the investigators. It was a 3-person oversight committee, and what their relationships were is unclear. And troubling to me as a biostatistician, the statistical analysis plan wasn't even published until years later. So, okay, your antennas go up. What's going on here? Let me tell you something about the endpoints here. So there was one primary endpoint in the original protocol called improvement, and there was a major pre-specified secondary endpoint of recovery. Improvement was a composite binary outcome comprising several criteria that we'll get into in a moment. And sometime a year after the data collection was locked and before the publication in this unblinded trial, the primary endpoint was changed into 2 continuous measures. One of the measures was the Chalder Fatigue Questionnaire. Trudy Chalder was one of the co-authors of the PACE publication. She created this questionnaire to measure fatigue. And it was changed from a binary endpoint to a continuous measure. It's a quantitative scale. The other component was the physical function subscale of the SF-36, Common Quality of Life measure you're probably familiar with here. Why? Why were these endpoints changed? We can have a conversation about that later, but let me continue the description here. Recovery was the the main secondary endpoint, and it too originally was pre-specified as a composite measure based on 4 criteria, one involving the same Chalder Fatigue Questionnaire, the same SF-36 physical function subscale, plus criteria related to a clinical global impression and also various definitions of caseness. As you can imagine, what constitutes a positive diagnosis of ME/CFS has evolved over our familiarity with the syndrome, and it is not a trivial or obvious type of diagnosis. Again, the criteria for those components changed mysteriously between the end of the trial, essentially, and the publication. I don't want to spend too much getting lost in the details of the measures, but I do want to run quickly through it so that you'll see and know what I'm talking about here. So for the primary endpoint, one component was a minimum score of 75 on the SF-36, 100-point physical function subscale, or increase in the physical function score toward the better end of 50% or more compared to baseline. And some other components, which I'll get to in the next slide. But this particular criterion was changed into at least an 8-point increase in the 100-point SF-36 scale. So now it's getting a little bit hard to calibrate. How do you translate a minimum score of 75 or a 50% increase into what does an 8-point increase mean? That's the first component. The next component originally was of the 11 fatigue-related items in the Chalder Fatigue Questionnaire, 3 or fewer, which the patient would self-rate as worse or much worse than prior to the illness onset, or the total number of items rated worse or much worse dropped by at least 50%. So that was the original criterion. It was changed to at least a 2-point decrease in the 33-point Chalder Fatigue Questionnaire. Again, moving to a more continuous flavor. In addition, the next component, you had to qualify as having a minimum score of 85 on the SF-36. That ended the changed criteria. There were 2 criteria for the primary endpoint of improvement. With respect to recovery, which, remember, got a lot of publicity, there were several components. One is a minimum score of 85 on the SF-36 physical function scale. That changed to a minimum score of 60. So they made it a lot easier to recover in this particular component. Originally, you also had to have 3 or fewer rated as worse or much worse on the fatigue questionnaire. That now changed to a maximum score of 18 on the 33-point CFQ. Next, in the clinical global impression scale, the CGI, originally you had to self-rate as very much better. Now, your overall health had to be either much better or very much better. And finally, originally, the case definition was met if the patient no longer fulfilled, for recovery purposes, the Oxford case definition of CFS, the CDC criteria, and the London ME criteria. In other words, there were three groups: Oxford, CDC here in the US, and London group. And if the patient met any of those, they would not be considered recovered. Originally, they had to not be considered a case anymore on all three in order to be considered recovered. By the time the publication came out, now the patient didn't meet the standard Oxford case definition, or on the shoulder fatigue questionnaire, they rated less than 6 of the 11 fatigue items as being worse, or their SF-36 physical function score was greater than 65. So again, it's hard to know just by reading these changes what exactly we should expect from this, but you can see that there were major substantial changes to this definition. So as a result of these changes, fully 13% of patients were already recovered, and then that got exaggerated into within the normal range at the start of the study for self-reported physical function. In other words, congratulations, you are eligible. With your consent, you are enrolled in the trial. Oh, congratulations, you're now recovered. That's weird, right? And this is what David Tuller brought to my attention originally. He said, have you ever seen anything like this? And I said, I have to be honest, no, I've never seen anything like that. It seems rather amateurish to me. But it gets worse. The investigators did not publish the findings for the original endpoints as specified in the protocol, even as a sensitivity analysis. You would think that if there was an originally specified statistical analysis plan, and for whatever cogent reasons you had to make a change in the definition of the endpoints, you owe it to the public and the scientific community, as well as the patients, to report what the original endpoints might have been, and then have a conversation about if and whether there was any differences in the conclusions. They didn't do that. In fact, when patients, for other peculiarity reasons, started to complain and began to demand release of the data, the investigators dug in their heels and actually accused the patient's requests as vexatious. Vexatious is a very interesting word. You know, it has a colloquial sense. If somebody's being vexatious, you know, they're annoying, right? But it also is a term of art in the law. If a lawsuit is classified as being vexatious, it means that it's a frivolous lawsuit whose sole purpose is to harass the respondent. So when they called these requests vexatious, they were essentially threatening their own participants with legal recourse. As we already mentioned, the PACE trial claims of successful improvement and recovery were based solely on subjective outcomes, notwithstanding the fact that the original protocol did have objective measures. There were 4 objective measures: a walking test, the 6-minute walk test. How far can you walk in a 6-minute interval? A fitness test related to oxygen consumption. It's the VO2 max by a step test. Data from governmental databases on days lost from work 6 months after the primary endpoint was measured. And the 4th objective measure was the receipt of financial benefits for disability. Those original objective measures fail to provide any evidence to support claims of efficacy for any of those treatments. So again, you're scratching your head and saying, so wait, what's going on here? There was one objective measure, I should correct myself, and that was the 6-minute walk test, which found that GET, but not CBT, participants walked reliably, meaning significantly further or farther than control participants at the time of the primary endpoint, which was measured 52 weeks after randomization. So if CBT and GET were both found to be significantly better for improvement and recovery, how come only one of those manifested in the 6-minute walk test, but not the other? But for those knowledgeable about this particular test, the quantitative difference was that the GET group walked on average 6 to 7 meters farther than they did on baseline, and the controls walked about 30 meters farther than baseline. So there was already what you might call a placebo effect or an improvement effect, even in the controls. And so you want to wonder, is that 47 meters significant, meaning clinically significant? To put it in context, a sample of class 2 chronic heart failure patients with similar baseline walking distances as those in the PACE trial increased their distance by an average of 141 meters after only 3 weeks of a much gentler graded exercise program. So to put it in context, okay, this was a significant finding, but you might say, well, does this qualify to getting back to normal? But it gets worse. I hope you're gathering from my negative affect that changing primary endpoints and secondary endpoints in a complex way without a great deal of cogent, compelling justification is something you should not do in a randomized controlled trial. There may be statistical arguments. For example, if it turns out upon interim analyses that the power of the test is nowhere near as high as was assumed during the planning stages, then a very careful, very rigorous data safety monitoring board examination is entitled to approve a major change like this. But again, there are much more profound difficulties for doing this in the context of an unblinded and self-reported outcome type of measurement, and we'll get to that later in the talk. Here's another question David Tuller put to me. In the middle of the study, the PACE team published a newsletter for participants that included glowing testimonials from earlier trial subjects about how much the therapy and treatments helped them. The newsletter also included an article informing participants that the 2 interventions pioneered by the investigators. Wait a second. So the 2 main investigators were pioneers in the development of these interventions, eh? The 2 interventions, CBT and GET, had been recommended as treatments by a UK government committee, quote, based on the best available evidence. Now, I'm not exactly sure what evidence they're talking about. One of the ethical principles of randomized controlled trials, as I'm sure you understand, is that there must be clinical equipoise in the community about with a palpable lack of consensus about which is the best treatment. Everybody is familiar with that definition of clinical equipoise. Less well known, but equally important, is a second part of the principle of clinical equipoise, which is that anything that you do that would threaten the ability of the trial to perturb the state of clinical equipoise and affect ongoing medical practice is unethical. This is the reason why phase 3 randomized controlled trials are supposed to be adequately powered. In other words, have a large enough sample size, because you need that large sample size in order to compel or have compelling evidence to the clinical community that one treatment is superior to the other, and then get doctors to move to that evidence base. Or, on the contrary, to have a large enough sample size to conclude that no statistically significant difference actually means there's a very trivial and unimportant clinical difference. So if you don't have a large enough sample size, you're violating that ethical principle, and it can be said legitimately that the trial is unethical. I would argue similarly, changes such as the ones we've been discussing today, which threaten the validity of the trial and which therefore inhibit the ability to perturb the state of clinical equipoise, is similarly unethical. But, we don't have to get as subtle as that. That newsletter didn't mention that a key PACE investigator was also serving on the very same government committee that endorsed the PACE therapies. Not cool. Even without that conflict of interest issue, I would never consider publishing a newsletter in the middle of the trial. The recruitment had not even been complete yet, and then never mind the follow-up, that announced that 2 of the therapies were now approved by a government committee as being endorsed as therapy for this illness. Why? Because you're going to ruin your ability to recruit patients. What patient would agree to be randomized in a trial where a government authoritative body has just approved 2 of the therapies but not the others? It threatened to destroy the very first leg of that clinical equipoise principle. And because of that, I was quoted in the media as calling the conduct of this trial the height of amateurism, and I stand by that opinion. It gets worse. The PACE protocol contained an explicit commitment to tell prospective participants about conflicts of interest. The investigators had long-standing financial and consulting ties with disability insurance companies, having advised them for years that CBT and could get claimants off benefits and back to work. Okay, this happens, but guess what wasn't stated in the informed consent form? Nobody was told about this potential conflict of interest. When the patients learned about this, they were furious. They were furious, and rightly so. All right, so plenty of funny things going on here. So what happened? 2 years ago, one of the patients whom I acknowledged, Alan Matthews, an Australian patient, sued the home institution of the PACE investigators, Queen Mary University of London, in a Freedom of Information action, a UK FOIA request to get the originally specified endpoints released. Initially, the PACE investigators refused. Nope, not going to do it. Why not? They were very concerned with protecting the confidentiality of the identity of the patients. If we give out the data, some unscrupulous, vexatious person might de-identify the data and find them out. A tribunal was assembled, and the tribunal decided to side with the patient, Alan Matthews. Queen Mary University of London appealed. Nope, not going to do it. A second tribunal was formed, and the second tribunal again came down, this time with a court order: you shall release those data. And so they did. Except they didn't release all the data. They withheld certain demographic variables, which they claimed could still be used for de-identification purposes. But they did release the unstratified data. So in the original trial, it was a stratified randomization technique that was being used. And of course, there's a principle of trial analysis that says if you randomize within strata, you should analyze the data similarly within strata. Those of us involved in the reanalysis of the original endpoints could not replicate the stratified analysis because we weren't given the variables that would tell us what stratum the patient belonged to. I don't think that made much of a difference because in a randomized study, because you're randomizing within strata, when you ignore the stratification, you don't get a lot of bias typically. But there is the potential for small differences nevertheless. So some of the data were released, and analyses of those data have confirmed that the extensive outcome switching allowed the investigators to report dramatically better findings than the null or the minimal results obtained with the originally pre-specified measures. Specifically, on the original protocol-specified primary outcome measure, overall improvement, there was a significant effect of treatment group. Now, I'm not denying the existence of the statistical significance of that group difference. However, the groups receiving CBT or GET did not significantly outperform the control group after correcting for the number of comparisons, as was pre-specified in the statistical analysis plan. Let me try to disentangle a little bit what's going on here. So remember, when the investigators switched the primary outcome, they created two continuous measures. So in the PACE publication that's circulating, you'll see that there was such and such a quantitative mean point differential between the two groups. But the authors did also publish the binary components, which had also been revised by the changes in those criteria that I showed you earlier. So in our reanalysis, the best we could do was to compare the original criteria that went to the composite binary with the new criteria that were published. And that's what we're talking about here. In the original SAP, Statistical Analysis Plan, the investigators said they would quote significance after a Bonferroni adjustment for 6 comparisons because they had 6 endpoints, and that's what they said they would do. In the publication, somehow mysteriously that 6 went to 5. We don't know why Bonferroni 6 changed to Bonferroni 5, but it did. And I'll show you some numbers in a moment. But before we get too hung up over whether something's significant or whether it survives a Bonferroni adjustment for multiple comparisons, the elephant in the room here is potential bias. And I want to finish the rest of my talk with an examination of potential bias here. But just to tell you, give you a flavor of what happened. In the published report for the primary endpoint of overall improvement, the CBT group, 59% of them qualified compared to 45 in the control group. And that difference was slightly larger than a p-value of 0.01. So if you multiply by 6 or even 5, you aren't allowed to claim statistical significance. But in the trial protocol with the original definitions, there was still a difference of about 10 percentage points. The CBT and GET did about 20% of the patients with the original definitions as compared to 10%. And again, p-values of 0.015 or 0.01, technically not statistically significant. What take-home message do you bring from this situation? Technically not significant, but it looks significant. There's an important element of any scientific endeavor, which is a priorism. If you say you're going to do something and you get funded to do it and approved by all kinds of review committees, then you ought to do it. You're not allowed to wiggle out of it and say, oh, but look, the p-value is 0.01. Never mind the fact that we said the p-value adjusted would be 0.06 or whatever. It's not good science, not good statistics. Recovery is even more shocking. Yeah?
So if you just go back, I'm confused, like you're saying that not statistically significant.
So the p-value here is the unadjusted p-value. If you just compare 20% for CBT with 10% for standard, that, do a 2x2 table, that gives you a p-value of 0.015. But you can't claim that as statistically significant until you multiply by 6, according to the original protocol. So it should have been stated as not significant, p equals 0.065 or whatever the product is. The rates of recovery as the main secondary endpoint were consistently low and not significantly different across the treatment groups. So here you see in the published report, they got 22% of patients having recovered. Great. Compared to only 7% in the control group. But when you use the original, more stringent criteria, which patients tell me, by the way, that original criterion was much closer to what a patient or a clinician would consider as having been recovered or partially recovered. The rates were small, 7%, 4% versus 3%, and certainly not significant. So what happened here was, by this redefinition, it allowed the investigators to massively exaggerate the success of the trial results. I'm not saying that CBT does not help patients. I'm saying that the characterization of the results, the exaggeration of the results, and the spin that these investigators have applied to the results are not really justified. On other secondary measures, significant effects were almost entirely confined to self-report measures, and everything disappeared after a 2-year long-term follow-up period. The primary endpoint was measured at 1 year, 52 weeks, but there was a long-term follow-up in a subset of patients, and the effects had gone away. And there's a whole controversy as well, which I can't get into for lack of time, about how come the effects disappeared after 2 years. So Carolyn Wilshire and Tom Kinlan and Alan Matthews and myself as co-authors published in the British BMC Psychology that these reanalysis findings raise serious concerns about the robustness of the claims made about the efficacy of CBT. The modest treatment effects we wrote obtained on self-report measures in the PACE trial do not exceed what could be reasonably accounted for by participant reporting biases. Let me quickly go over those bias issues, because these are perhaps the most important things to note. Heavy reliance on self-reports from participants who are aware of their treatment allocation raises concerns. Now, of course, in behavioral intervention trials, full blinding is often not possible, like in the PACE trial. But in that situation, it is the researcher's responsibility, it behooves the researchers to consider the possible effects of the lack of blinding on outcomes, especially subjective self-report outcomes, and to ensure that such factors would not rise to the level where it might account for the apparent findings of benefit in the trial. In a trial that's not blinded, self-reported outcomes, it is well known, can produce highly inflated estimates of treatment-related benefits, and I would argue this trial is a good example of that. Given that there's a known discrepancy in the effects of blinding on subjective versus objective measures, it appears unlikely that the improvement and recovery effects, sad to say, reflect genuine health benefits. We feel a much more plausible explanation is that there are expectation-related artifacts that reflect the operation of attentional biases that favor the reporting of events consistent with one's expectations, possibly recall or confirmation bias that enhance recollection for events as consistent with the patient's expectations. Now that sounds a complicated mouthful. What does that mean? And, you know, full disclosure, the PACE investigators discount that alternative explanation. They've argued that expectancy effects alone cannot account for the positive self-reported improvements because by randomization, patients' expectations were the same across the groups. But what they fail to point out is that these two interventions, CBT and GET, the participants were primed during the treatment period to expect improvement. The manual given to the patients for CBT proclaims CBT to be a powerful and safe treatment which has been shown to be effective in this illness. The GET participants' patient manuals said it's one of the most effective therapies currently known. And both interventions emphasize that faithful adherence to the program could lead to a full recovery. But guess what? You know, you think you raise patients' expectations? Yeah, I think so. And guess what? No such statements were given to the other two treatment groups. As if that isn't grounds for sufficient bias, and this is my last substantive point here, the very treatment itself of CBT, and to a lesser extent GET, was that you should stop focusing on your symptoms. Let's get off this notion that your symptoms are stressful and debilitating to you. You know, if we can only get you properly psychologically conditioned, you'll feel a whole lot better. So stop reporting all these bad symptoms, you know, don't focus on it. No such instruction were given to the other group, the control group. And so guess what? When your primary endpoint asks patients to self-report their symptoms, what do you think is going to happen? It's outrageous, actually. To wrap up, here are some consequences. The story is far from over. In fact, David Teller emailed me just before today's talk to say that the Times of London and the British Medical Journal have both picked up news stories about the topics we're discussing here, and in particular his open letter to the Lancet, letter number 3 to the editor of the Lancet. But even before that, up to date, the AHRQ downgraded its recommendations for CBT and GET. The grading occurred because the agency actually removed the PACE trial from its meta-analysis. The PACE investigators claim that GET is safe, Remember, graded exercise therapy is you slowly raise the level of exercise, you don't overdo it, you let the patient acclimate, and that's safe. But AHRQ begged to differ. They said that GET was associated with more adverse events. The US CDC abandoned its recommendations that patients be treated with these two therapies. A couple of months later, the UK National Institute of Health and Care Excellence announced that it would undertake a major reanalysis. I don't know what outcomes they've found yet, and I'm interested to see. The Dutch Health Council recommended GET should not be used in the Netherlands as a treatment. And just this past March, a leading group of American clinicians who specialize in the illness unanimously agreed that the two PACE treatments are inappropriate and possibly harmful for patients with the illness and should therefore not be prescribed. So these are pretty serious consequences, and I think it shows that the ability of this trial to perturb the state of clinical equipoise failed because of inappropriate conduct of the trial. And as I said, in my opinion, that's unethical. So I want to thank you very much. If you want to read everything that I said today, go to Vince Racaniello's virology blog. There's the URL, and you can read about it in David's own words, in particular the third open letter to the Lancet. There's a whole other story about why the editor, John Horton of the Lancet, has refused to even entertain critical publications to have a scientific debate. But that's a whole other story. So thank you very much.